Arleen Brown to speak at Medicine Grand Rounds this morning. Dr. Brown is a professor of medicine in the Center for Health Services at the University of California, Los Angeles, and division chief of general internal medicine at the Olive View UCLA Medical Center. She also serves as co-director for the Community Engagement and Research Program at the UCLA Clinical and Translational Research Institute. Dr. Brown earned her medical degree and completed her house staff training at the University of California, San Francisco, and then completed a one-year fellowship in medical effectiveness research, also at UCSF. She then transitioned to UCLA as a Robert Wood Johnson Scholar and earned her PhD in public health and preventative medicine. Dr. Brown's research interests are in population health, focusing on healthcare systems and social and individual level determinants of health. This research has spanned a wide range of diseases in patient populations, including cardiovascular risk reduction in ethnic minority patients living with HIV infection, racial and ethnic differences in stroke prevention and outcome, and understanding healthcare disparities in the treatment of and prevention of diabetes. Please join me in welcoming Dr. Brown as she presents Population Health Approaches to Reduce Health Disparities.
Thank you, Ryan, for that really lovely introduction. Thank you all for inviting me to speak this morning. So as Ryan mentioned, I'm going to be talking about population health approaches to reducing health disparities. And let me see, there we go. I want to just present a brief overview of what I'm going to talk about today. So the first is really just a rationale for why we want to look at disparities and rationales for promoting equity. And then I want to talk about population health approaches to measuring, understanding, and mitigating disparities. So both measuring and tracking them, understanding causal relationships, developing testing and implementing and testing interventions, and then facilitating multi-sector collaborations, all of which I think are critical to disparities reduction. So first, what is a disparity? So there are many different definitions of disparities floating out there. This one is probably the one that's been most commonly used, and it focuses mostly on healthcare. So it's differences in the quality of healthcare that are not caused by differences in clinical need or patient preferences or the appropriateness of interventions. And that really is, again, healthcare disparities. If we take a step back and think about some of the factors that contribute to health disparities, then this definition is probably more appropriate. Differences in health that are not only unnecessary and unavoidable, but are considered unfair and unjust. And then these are all tightly linked to the notion of health equity. So the goal there is to attain the highest level of health for all persons in your environment. And the goal is really to ensure that everyone has full and equal access to opportunities that enable them to lead healthy lives. So this takes us out into the population. Now, there are several reasons for focusing on disparities. First of all, our population within the US is becoming increasingly diverse, and many of these subgroups have high rates of disparities, but not only racial and ethnic minorities, but also those with low income, rural populations, sexual minorities, and those with low English proficiency. There's also increasing evidence that higher quality of care is associated with reduction in some disparities. And finally, the human and societal costs are tremendous from health inequities. And they contribute both to financial costs, but also morbidity and mortality. So this is a slide that I like that comes from the US Census projections. And they projected out I forgot this. Here we go. They project out from 2010 to 2050 the proportion of the US population of different racial and ethnic categories. And what initially, in 2010, we had about 65% of the population was white, 16% Latino, 5% Asian, and over 13% African American. Projecting out to 2050, we expect to see about 46% white, 30% Latino, 9% Asian, and 15% African American. So a much different looking populace. The second reason that I mentioned is that it's actually been formally recognized as a measure of quality. The IOM and now National Academy of Medicine define these dimensions as safety, efficiency, timeliness, effectiveness, and patient-centeredness, and then equity.
And there's evidence from multiple studies that higher quality of care reduces delays in obtaining needed care, promotes efficacy and safety and reduces errors, and promotes respect for patient values, preferences, and needs. And these are all associated with efforts to reduce disparities. And then finally, the cost. A relatively recent set of publications from the Joint Center for Political and Economic Studies found that between 2003 and 2006, the cost of chronic disease disparities that contributed to both health inequalities and premature death in the US was over $1 trillion. They also estimated that by eliminating health disparities for racial and ethnic minority patients, they could have reduced direct medical expenditures by over $225 billion. So these costs are really staggering. So there's a lot of focus recently on the notion of population health. And, you know, there are many different, again, like disparities, there are many different definitions floating out there. And population health is really a strategy that provides tools for identifying, understanding, and intervening upon health disparities. And I want to talk about how that might happen. And this is both within and outside of the healthcare system. So what is population health? It's the health outcomes of a group of individuals and the distribution of these outcomes within the group. And this is really a set of, this builds on a lot of work from David Kindig and Stoddard dating back to the early 2000s. And within population health, the focus is on identifying and tracking health outcomes for groups at high risk for poor outcomes, determining how the healthcare system and other sectors can improve outcomes for both the population, for both those at higher risk and the population as a whole. So, within health systems, though, what we call population health is actually another field called population health management. And this is really a health industry term that refers to aggregating patient data across a lot of health systems and a lot of information technology resources, analysis of that data into a single actionable patient record, and then the health system actually taking actions that can improve both clinical and financial outcomes. We tend to focus on this component of population health. It's one piece of it. And I think I really want to make sure that we think about both the population health as a whole and population health management. And this is actually a slide that walks us through this notion of population health and population health management. So the population health management components are kind of these big data, predictive analytics, and risk stratification, provider and health system engagement, subpopulation identification and performance monitoring, and data sharing. What tends to get lost in the population health management focus is an emphasis on patient engagement and community engagement, and also multi-sector coordination. How do we improve health outcomes by really extending beyond the walls of the health system? So now I want to talk about how what we describe as population health can actually contribute to our understanding of and mitigation of disparities. So the overall approach that many have suggested is that, you know, these approaches can link the delivery system with the community and the patient, identify clinical performance measures that can be reported at the community level rather than just the delivery system level, and then apply the metrics in a consistent manner across the population, not just on who is in your plan, but really think strategically about the other folks in the population or people in your plan who actually aren't coming into your health system. So, and critical to this is measurement. And I can't emphasize this enough. In order to understand disparities, it's really crucial to measure and track them and understand unwanted variation in those measurements. So, I want to first, this is a cartoon that I like because I think it highlights some of the problems we have with measurement. So this is, I think, an OBGYN talking to an expectant father and he says, it's a baby, but federal regulations prohibit our mentioning its age, race, or gender. And this, unfortunately, is a problem that we have had in thinking about racial ethnic disparities in particular, but a whole host of disparities within our health systems. So this slide comes, sort of crystallizes some some recommendations from a project that we worked on through the Disparities Task Force in the Society for General Internal Medicine. It was led by Donna Washington at UCLA. And there's a notion that collecting racial and ethnic data is illegal. And we talked about the fact that in this paper that it's actually legal in most states, and actually in California it's required. That it can be really difficult for staff to ask about this. But I think as we've learned, many staff are very comfortable asking these types of questions, and they can be trained. Staff and faculty can be trained to collect a lot of these data sensitively and efficiently. These types of data can also be collected directly through the electronic health record. And finally, that it's intrusive to patients. What we've seen time and again is that patients generally respond positively if they understand why you're asking the question. Now, another component of measurement is our tendency within the healthcare environment to lump in some cases and split in others. And this is an example that I think is helpful to me when I think about why we want to disaggregate information. So this is just a look, this is from a series of papers that described diabetes prevalence in various subgroups. And the general trend here is that whites have the lowest rates, followed by Asian Americans, Latinos, non-Hispanic Blacks, and American Indians and Alaska Natives. Now, if we break down the Asian American group, we see really almost a threefold difference in rates of diabetes when you compare Chinese Americans to South Asians. When we further break down the Latino group, again, we see pretty dramatic differences between Central and South Americans and Puerto Rican Americans. Now, I think another component of understanding disparities and really trying to intervene on them is really think about how well we're doing with some of our large population health efforts. Healthy People 2020, as many of you know, is this ongoing, every 10-year evidence-based group of national objectives for reducing disparities in our population. And the goals are really to attain higher quality, longer years of healthy life, creating social and physical environments that promote good health for all, promoting quality of life, healthy development, and health behaviors across all life stages, and then finally achieving health equity and eliminating disparities, improving the health of all groups. And that last bullet was actually added with Healthy People 2020 it actually wasn't in Healthy People 2010. So one of a project that we undertook was to try to understand how well we were doing on some of these metrics over time. Cardiovascular disease disparities are a leading cause of early mortality and morbidity among minority adults. We see it at a much younger age as well. And these CVD risk factors are among the leading health indicators for Healthy People 2020. But one thing that we had found is that there was actually very little data and how these disparities had changed over time in response to, a host of interventions that had been implemented across the U.S. in the public health sector to try to mitigate disparities and improve overall population health. So we asked the question whether the CVD and stroke risk factors that contribute disproportionately to early morbidity and mortality among African Americans and Latinos had actually changed over time. And we used data from NHANES, the National Health and Nutrition Examination Survey. So we looked at three groups. We looked at race, ethnicity, and nativity. So we looked at whites, African Americans, US-born Mexican Americans, and Mexican Americans born outside the US. Then we looked at three age groups. The young group was 25 to 44, middle age 45 to 64, and then 65 and older. And we looked across NHANES time periods, starting in NHANES 3, which was 1988 to 94, all the way to the most recent data we had available, 2011 to 2014. So NHANES 3 is about a 6-7 year time period, and then the other waves are 4 years. And we excluded, because we were focused on prevention, we excluded those who reported a prevalent stroke, MI, angina, or heart failure. So we looked, our outcome was Life Simple 7, which incorporates 7 of the metrics from Healthy People 2020. So we looked at blood pressure, cholesterol, hemoglobin A1C, body mass index, physical activity, healthy diet, and smoking. And we rated folks, the Life Simple 7 rates individuals on these metrics from poor to ideal. You get a score of 0 if it's poor, 1 if it's intermediate, and 2 if it's ideal. So an example would be if you never smoked, you get a 2. If you're a former smoker, you get a 1. If you're currently smoking, you get a 0. And then so the total score is the total potential score is 14. And there's a category that's been used in the literature called optimal cardiovascular health. That's a score between 10 and 14. So we looked at the individual metrics, and then we looked at how well we were doing in terms of this optimal cardiovascular health score. We used linear regression models that adjusted for age, gender, education, and income to poverty ratio as a measure of individual SES. And we bootstrapped the confidence intervals. And so I'm going to just show you the overall finding in terms of the trends. And I'll orient you to this slide because basically the x-axis shows each time period from NHANES 3 up to 2011 to 2014. The y-axis looks at the proportion of the population with optimal cardiovascular health. And then non-Hispanic whites are in this top purple line, African Americans are in the orange line, Mexican Americans born in the US are in the dark blue line, and then foreign-born Mexican Americans are the light blue line. And so as you can see, we're not doing that well. So at our best, at the earliest time period, we had 40% of the white population had optimal cardiovascular health, but about 25% to 30% of the Mexican American population, and then under 20% of African Americans. And generally, folks got worse, with the most dramatic decline among whites. We then looked at, next I'll just show you the other age groups. And you can see the trend is very similar in the middle age group, though the proportion with optimal cardiovascular health drops overall. And then sort of flattening of the curve among those 65 and older. Now, I'm going to take a couple of other looks at this data. So this just looks first at the disparities. So you see that in the youngest age group, everyone here, it's compared to whites in each time period. So in the youngest age groups, there's a 21% difference between whites and blacks in 88 to 94. It's 12.7% among US-born Mexican Americans, 11% among non-US-born Mexican Americans. You see a decline in the absolute difference over time for most groups, so an increase among US-born Mexican Americans. But everything in red and bold is significant. So you see that this disparity, you had a disparity across the board in NHANES 3. And then you see maybe pretty similar in 99 to 2000. And then over the years, you see a little, see a few places where the disparities disappear. But for the most part, you see persistent disparities over time. Now, taking a look at within each racial ethnic group, we see something that's pretty striking that I think the curves don't show as well. So these are whites over time. So the reference group for each racial ethnic group is that racial ethnic group in 88 to 94. And what we see is for whites, there's just this decline over time in rates of optimal cardiovascular health. A decline that you don't see as consistently or at all in the other racial ethnic groups in different age groups. So just to summarize these data, I think it suggests that our efforts under Healthy People 2020 have not been as robust as we would like. So we see that the disparities in cardiovascular health persist, over time, we're seeing a decline in the disparities between whites and other groups, but it's not for the reasons we would like to see. It's not because everyone's getting better. It's actually because everyone's getting worse, and whites are getting worse at a faster rate than everybody else. So why? And so we actually tried to tease this out a little bit. So these are just sort of general trends for each of the metrics. And so we divided these out into the biologic and the behavioral risk factors. And so what you see is that for hypertension, generally, you see a trend towards better control. So here we see, these are the percent with poor control for each metric. Total cholesterol, generally better control over time, particularly in the oldest age group. And the rates of diabetes and prediabetes are skyrocketing. Rates of high BMI are increasing. Rates of sedentary lifestyle increasing, poor diet increasing. Current smoking is, one thing that looks a lot better over time. So just to conclude this, to summarize some of these data, as I mentioned before, the cardiovascular health of our nation seems to be on the decline. And although racial, ethnic and nativity disparities persist, the decreases are really for the wrong reasons. And I think we're also seeing variation in trends in the underlying risk factors, and it's variation that is potentially actionable. So it really suggests that we need to use different strategies for some of the risk factors than we've been using, some at the population level, some at the clinic level, some at the community level, and that we actually do have some bright spots, particularly smoking. So finally, just to summarize the issues around measurement, I think one of the things that these analyses, I think, suggest to me is that it's really critical to understand the data we already have and to think about ways that we can use administrative data, electronic health record data, service use and medication data to really track some of these differences over time and across groups. And here, for the analyses that I presented, we looked at racial ethnic subgroups, but we could just as easily have looked at something like limited English proficiency or gender disparities. And the other thing that I think is really critical, particularly within health systems, but also in public health departments, is to build expertise, the data analytic expertise, things like natural language processing, but also using strategies like implementation science and qualitative analyses to try to get at what's underlying some of the disparities that we're seeing. And finally, I think really thinking critically about ways to think outside of our health systems to obtain qualitative data from people who include patients, staff, our communities and community agencies and other stakeholders to try to understand some of the trends that we're seeing. So I'm going to move on now to that piece, understanding the causal relationships. So this is a well-known figure that comes from Tarlov and from the Annals of the New York Academy of Science that really tries to tease out our best guess of the contribution of different factors to overall health and health disparities. And I think I want to highlight a couple of things. One that as always concerns me is that clinical care contributes about 10% to our overall well-being. Genes and biology, another 10%. Our health behavior is about 30%. But it's really our physical environment and social and economic factors contribute about 50% to our overall well-being and contribute dramatically to the disparities that we see. And this is one example that that came from some analyses that we did with cardiovascular health study data. This was analysis that we did with Will Longstreth about looking at stroke. I think for me, one of the most important findings was it had nothing to do with stroke, but it had to do with where people live and the impact of that on health. So this is actually, we looked at something called neighborhood socioeconomic status. So it uses about 6 measures from the US Census that are proxies for wealth, education, income, and employment at the neighborhood level. And it aggregates these, and you get an overall impression of what that neighborhood socioeconomic status looks like. So it gets divided into quartiles with a Z-score, so you can have a negative neighborhood socioeconomic status in terms of this score. But what struck us is that was overall. So in the orange lines are whites, the blue lines are African Americans. And this probably doesn't surprise you. I mean, this is something we all know. People of different races often live in very different communities. But I think this was really striking to us, that when you looked at the quartiles for African Americans versus the quartiles for whites, there was sometimes no overlap. And actually, the whites in the lowest socioeconomic status neighborhood actually had a higher NSES than African Americans in the bottom three NSES categories. So it's actually really, I think, a profound figure that profoundly, I think, illustrates this separation of people into communities. We use this to take a look at the impact of neighborhood on stroke risk and outcomes. And I'm just going to share with you one figure from that analysis. Again, I mentioned it was from the Cardiovascular Health Study data, which is looked at residents of 4 counties, Sacramento, Allegheny County, Pennsylvania, Washington County, Georgia, and Forsyth County, North Carolina. And the overall cohort included about 6,000 people. We looked at the folks who had had strokes until about 2006, 2007. So there are about 650 people. And we used multi-level models or frailty models to look at that were adjusted for demographics, behaviors, comorbidities, and clinical factors, as well as neighborhood SES. And what we found is that at 1 year, if you lived in the neighborhood with the lowest socioeconomic status, your risk of death after a stroke was the hazard ratio was 1.77. So you had a 77% higher chance of dying than people in the top 2 categories. So this is actually pretty striking, that neighborhood seems to be playing such an impact. Where you live has an impact. We don't know why. It was really, we tried to tease out characteristics of the neighborhoods. It may be the resources available. It may be social support. It may be clinical care. There's some evidence from the UK that clinical care is a factor in the neighborhood disparities that we see. But this is actually, I think, something that is quite striking, and it suggests that we need to think beyond our healthcare system to understand kind of what's going on in communities for the patients that we care for. And just to sort of summarize some of the literature and some of what's known about neighborhood factors, we know that residents in more disadvantaged neighborhoods are associated with fewer educational employment opportunities, fewer and lower quality clinical resources, more restricted ability to engage in self-care, and poorer management of medication, dietary, and exercise regimens. And so I think this is a factor that we need to consider, and I think forces us to consider collaborating with community partners as we think about how to address some of these issues. So this has been a pretty bleak presentation to this point in some ways, but I think I want to make sure that we think about how we might develop, implement, and test solutions using some of these population health approaches. And this is an interesting example from Kaiser that I think it really forces you to think about both the population level effect and then the subgroup level effect. So Kaiser started an initiative to improve blood pressure control. I think this was Northern California Kaiser. And so what you see here are the trends in control over time. The triangles are national data. The circles are Kaiser data, and the squares, which started about 2006, are California statewide data. So what their initiative included a comprehensive hypertension registry, They developed and shared performance metrics across the institution. They disseminated evidence-based practice guidelines for stepped care. And then they had a medical assistant who was empowered to, at a blood pressure check visit, to call a provider and say, this person's out of control, what should we do now? And then they could send in a new prescription for a new medication when it was needed. They also promoted single pill combination therapy. So what you see here is that over time, Kaiser started off at about 44% of patients in control. The national mean at the time using HEDIS data was about 55%, and it rose from 2001 to 2009. Kaiser rose from 44 to 80%. The national mean rose only from 55 to 64%. So they basically really outpaced the nation by implementing the different components of this hypertension registry and program. And you can see that the California mean, which started around 2006, really didn't change that much. It went from 63% to 69%. Now, what's interesting here is that, so basically they raised the floor for everybody, it looks like. So in a local Kaiser in Southern California, they actually decided that, you know, their patients were a little bit different. They had a higher proportion of African American patients. They had, and they had worse control than the average Kaiser patient. So they actually took a step back and said, what can we do specifically for our patients in the setting of everything else that's going on? So they actually, they went through their registry. As patients came in, they offered them sort of more culturally tailored solutions. They actually talked about the different side effects more effectively of different medications. They had health fairs in the community in places like churches. And what they saw is that for their African American members, the rates went from 70% to 82%. Now, this was in the context of this ongoing intervention. And for their white members, they also saw an increase, but the gap narrowed. So this is kind of the way you want to see disparities improve, with everyone improving, but then you actually decrease the disparity between whites and blacks. So there are many other examples of ways that we might improve outcomes and decrease disparities within the clinical setting. This is an example from Nina Bickel in New York. So they actually worked with breast cancer surgeons at 6 New York City hospitals to try to reduce the disparities, the really profound disparities that we're seeing for African American and Latina women with breast cancer compared to white women. So they actually developed a registry that provided feedback and tracking to providers. So this really intervened mainly at the level of the providers. They sent reminders to surgeons whose patients had not visited an oncologist. So they'd had surgery, but then failed the oncology appointment. And they looked at completion of oncology referrals over the study period and the receipt of adjuvant therapy. So they used kind of these quasi-experimental methods. They used a pre-intervention cohort of women who had had breast cancer surgery between 1999 and 2000 as a comparator. And then compared that to the post-intervention cohort of about 300 women who'd had breast cancer surgery between 2004 and 2006. And this shows some of the baseline data. So at baseline, about 14% of Black and Latino women had not seen an oncologist, and about 18% of white women. When you look at actual breast cancer quality metrics, you see really stark disparities. No radiation therapy after the breast conserving surgery, 23% of Black and Latino women, 12% of white and Asian women. No chemotherapy, 26% compared to 18%. No hormonal therapy, 27% compared to 16%. And missing one or more adjuvant treatment, 30% compared to 19%. After this registry was implemented and the intervention implemented, here's what you saw. You saw that the rates of women who had not seen an oncologist dropped in all women, right? So they got down to about only 4% had not seen the oncologist. But the gaps really narrowed. So the proportion with no radiation therapy after surgery, 10% versus 13%. No chemotherapy, 6% versus 16%. No hormonal therapy, 11% compared to 6%. So that was still significantly different. And missing one or more adjuvant treatments, 13% versus 15%. So you can really use some of these strategies to narrow gaps and actually improve outcomes for everyone in your cohort, but actually narrow the gap as well. All right, so now I'm going to talk about some of the work that's been done completely outside of the health system. And this is a study that I really like. It's actually called Moving to Opportunity and Tranquility. Many of you may know it. So this was a randomized social experiment, and it was conducted by HUD, the Department of Housing and Urban Development. So what they did is, and there was no intention to do anything in the health, in terms of health. We were really looking at child educational outcomes and employment outcomes. So this was conducted with residents of public housing projects in 5 cities, so Baltimore, Boston, Chicago, Los Angeles, and New York. And they looked at those who lived in, so these were housing projects where the percent poverty in the community was more than 40%. And then they randomized people to one of 3 conditions. You could get an experimental voucher where you could only move to a low poverty area. So you had to move to an area where the rates of poverty were less than 10%. You also got some short-term counseling on how to do a housing search to get into those areas. Then you could get a traditional voucher, which is a Section 8 voucher, where there are no restrictions on geography, but because Section 8 housing is really limited, it's often hard to get that housing, but it's also often it's in high poverty areas. And then you had a control group who did not get a voucher. They followed these families, which were mainly African American and Latina women with children, for more than 12 years. And they compared data from about 99 to 98 to the 2008 to 2010. They conducted surveys with these families. And then they also assessed body mass index and rates of diabetes. Diabetes was assessed using just a blood spot for A1C. And what they found over 10 to 12 years, as expected, the experimental group were much less likely to reside in high poverty areas than the control groups. But they also had a 13% lower rate of obesity and a 22% lower rate of diabetes. Now, in absolute terms, this is not huge, but at a population level, this is a profound impact. So going from 31 to 35% in the 2 groups compared to 14% for diabetes to 17.7%. Now, they've done some work to try to explore the mechanisms for this. What they see, one thing they seem certain of is it doesn't seem like it's related to healthcare. There was no difference in access to local healthcare services or what they could determine about quality of care, though that was limited. But the types of things that differed between the 2 groups were things like higher reported collective efficacy. This is a measure of how likely it is that people in your neighborhood are going to look out for you. So if kids are vandalizing your home, is anyone going to report them? If they see someone in your community in trouble, does the neighborhood get together to try to help? And so the experimental group reported higher levels of collective efficacy. They were more likely to report feeling safe, and they had higher rates of having a friend who had graduated from college. So their social networks had changed. So their social circumstances had changed. And thinking about those mechanisms, it really is important to try to understand what is it about these communities that seem to be obesogenic and diabetogenic. Now this one sort of now takes us to a different plane. This is actually another study that was conducted in the state of Delaware. And it's an interesting study because in a way it combines the community level action with health system and public health action. So this was a paper that was entitled "It Took a Village," and the goal here was to try to understand ways to reduce colorectal cancer disparities in the state. So there was a statewide cancer control program that was formed in 2001, and they basically said we have to figure out, number one, how to improve rates of colorectal cancer screening, reduce rates of colorectal cancer deaths, but also reduce the profound disparities we're seeing between blacks and whites in the state. And this was a mandate from the governor. So they actually used a multi-pronged approach. They did CRC screening using nurse navigation and care coordination, and they did this at all 5 hospitals in the state. So it's a small state, it's relatively easy to do. They also provided cancer treatment for uninsured patients, and this was pre-Affordable Care Act. And then they also, as part of this, had the explicit goal of reducing the disparity. So what they did is they had tailored outreach programs to African American patients. So these were designed and marketed in collaboration with both the clinical entities, but also the community organizations, churches, community leaders. And they also, part of this project was to really start off with pre-specified outcomes. They wanted not only to look at the population level outcomes, but they wanted to look at the disparities outcomes. And they had several data sources that they were able to harness. They had the statewide screening program, the BRFSS, which is a behavioral risk factor survey, and that's available in all states. And then they had a Delaware cancer registry. So I'm going to show you a few figures from this. So this table just shows rate differences in rates of CRC, those who had ever had a colonoscopy in 2001, among blacks, it was 47.8, among whites, 58%. By 2009, that gap had disappeared, and both groups were higher at about 74%. When they looked at CRC, colorectal cancer incidence rates per 100,000, it went from almost 67 in blacks and 58 in whites to 44 and 43 respectively. And when they looked at CRC mortality, went from 31 in blacks per 100,000 and 19.5 in whites to 18 per 100,000 and 17 per 100,000 respectively. So you see that there was a bigger drop, a bigger change, a bigger increase in screening among blacks over this time period, and a bigger drop in incidence of colorectal cancer and in mortality from colorectal cancer in this group. And this is just sort of a figure that describes the scoping, so it's the colorectal cancer incidence rates in Delaware over this time period with, the disparity disappeared. And then colorectal cancer mortality, the disparity did not disappear, but it was greatly attenuated. So I think I think the studies that I described, argue for the importance of different types of partnerships to decrease disparities. So one of the things that one of my roles is to work on community engagement as part of my, as for our Clinical Translational Science Institute. And it's a thankless task at some points because you're having basically 2 different groups of people talking to you in 2 different languages about what's important. But I think it's really critical to get the players in the room to think about what's important to patients, what's important to communities, and what's important at the health system level. And the other piece of this I think is really critical, and I think it's really illustrated nicely by the Housing and Urban Development project, is that it's really critical to involve non-health sectors in the process. Much of what we call disparities are related to educational and employment opportunities. These are life course issues. And within the health system, the people we see are often, at the end stage, or we're working on secondary prevention rather than primary prevention. And I think if we're thinking realistically about how to change or how to reduce disparities, we've got to think about ways that our health systems can engage, our clinics can engage non-health sectors, whether it be housing, employment, the criminal justice system, or agriculture. All of those have huge and profound impacts on the health of the populace, but too often they are actually, there's this firewall between the clinical world and these other components of the world that people live in. The other thing that I think is really important as part of this process is thinking about workforce development. Clinicians, staff, and investigators are all interested in ways to create sustainable change to promote health equity, improve population health. But too often the people who are involved in that are divorced from the communities that are most affected. So I think thinking about ways that you might change the healthcare workforce to more reflect the people who are being cared for is really important. Right now, there's just a huge divide. There are a lot of pipeline programs that are in the works. There's a lot of cross-disciplinary and interprofessional training that's been proposed, but figuring out ways to entrench that is harder, and it's really critical. We also need people in a range of disciplines: health system research, health services research, bioinformatics, ethics, community engagement, cultural competence, community, and communication, who can actually intervene and think about ways that we might most effectively bring about the change that we'd all like to see in terms of improving the health of our populace. One of the projects that I would like to, that I actually am currently involved in is something called whole person care in California, where counties, as part of the Medicaid waiver, have been allowed to take funds and use them for non-health purposes. And by non-health purposes, it means housing for homeless patients. And so the County Department of Health Services in Los Angeles is now a landlord, and it's actually building apartment buildings, because they know that has a profound impact on not just rehospitalization, but also on first hospitalization for patients who are at risk. They're also working on prison reentry. We know that disproportionately affects men of color. And the problem is that when you're in jail, you actually sometimes, it's been shown that African American men actually receive better health care in jail than they do in the community. And but what happens is when you leave jail, you often don't know that the pill you were getting was actually for your blood pressure. So you're no longer being treated for that. You may be on dialysis when you're in prison, and you leave prison and there's no dialysis appointment set up. So they're actually working with the prison system in partnership to try to identify when people are going to be discharged, and when they're going to be, sort of the language of medicine, and when they're going to be, and where they should go, in terms of for healthcare, but then for all those wraparound services that are needed. So, I think some of what we get as pushback when we talk about this is, I went to medical school, or I went to nursing school, and this is not, what I had intended to focus on. But I think many of us recognize that no matter how many pills we prescribe, no matter how many therapies we provide, if we're not addressing people's fundamental needs in some way, or figuring out a way for them to help them get those resources, we are going to be in worse shape than we currently are. So I think this is an area for both research and service that is wide open at this point. We'll see how effective these strategies are in the next few years. This whole person care initiative right now is about 2 years in, and it's about a 4 or 5 year lifespan right now. It was funded in large part through the Affordable Care Act, so it's not clear whether which elements can be sustained without the Affordable Care Act in place. So I want to conclude by summarizing some of what I've talked about today. So first off, that a focus on health equity is really central to delivering high quality care in an increasingly diverse population. It's really critical to understand both overall and subgroup patterns of disparities in order to develop and sustain interventions. And disparities persist for many racial and ethnic groups, but we need better, more consistent data, better quality data, particularly for many of the understudied groups. So LGBTQ, low English proficiency, patients who have relatively small number in a population, but are profoundly affected by various disparities. And then I think health systems have a really key role to play in mitigating disparities, but they shouldn't go it alone, and they can't go it alone. So really thinking about ways that we can link the delivery system to community resources is, I think, the next step, and something that many of us are very interested in working on. And then finally, as I mentioned before, the importance of non-health sectors, housing, employment, transportation, in preventing and reducing disparities. So I want to just end by saying that really in order to enhance the effectiveness of our care delivery system and ultimately improve the health of our population, we really have to figure out ways to develop programs and policies that address the unmet needs of our patients and communities, intervene at a number of different levels. We often focus primarily on the individual level, the person sitting in front of us, but very often we have to think about their interpersonal relationships when they leave our clinics, the communities in which they're embedded, and the systems that interact with ours, and finally how we can collaborate across those systems. So thank you for your time and attention, and I'm happy to take questions.
Excellent talk. Very timely for us in UW Medicine as we focus increasingly on population care. One of our faculty, Joel Kaufman, was PI on the MESA study that really opened my eyes to the importance of air quality in predicting coronary disease. And I wonder, in the neighborhood data that you were showing there, you didn't list that specifically, but many neighborhoods have air quality problems, and that may be a hidden reason that there's more heart disease.
Yeah, that's a great question around air quality, and the MESA study is interesting. It's near and dear to my heart because for a time, I was out in our Alhambra site recruiting patients for MESA. And I think the MESA data can provide a lot of insight, partly because it is geocoded. So you have geocodes for the patients and where they've lived over time. But I think the air quality issue is a really big one, and particularly in large cities where you have these truck routes. In Los Angeles, you've got the port, and then you've got these trucks coming in, bringing in things from the port that go through these neighborhoods that have astronomical rates of childhood asthma. One of the solutions was to put kids on buses and bus them to schools outside of those communities. The problem is, I don't know if you've driven behind a school bus, but the particulates are, you can see them coming at you. And so it's a huge problem. There's actually been a lot of community action around this. And there are now initiatives to change the types of vehicles, but also think about where you put schools, where you put housing in relation to some of these these areas with very high density pollution. But I think there's so many, the interesting thing about neighborhood research is, our goal is always to try to distinguish the context from the composition so that you can figure out, are you in this poor neighborhood because you were sick, or are you sick because you're in this poor neighborhood? And, that may be impossible to determine. And I think instead, we have to recognize the fact that you've got these multiple layers of disadvantage that exist in a lot of communities. We also need to recognize that, it's not always all bad. And sometimes you've got these communities where you may have a lot of disadvantage, but they're sort of outliers. They do pretty well. And it may be because of social factors. So I think understanding the different exposures is really critical. And then thinking about both the unintended consequences of those different exposures, both what you expect to see and some of the things that may be happening that you don't anticipate. And so I think we really need to do much more work around the types of exposures and how they interact with each other.
Thank you for your talk. recently, Seattle implemented a sugar tax on sugar beverages. Are there data on how these kinds of policies affect disparities?
You know, not that I'm aware of. I know they did this in San Francisco, and I'm pretty sure somebody's looking at it right now, but I don't know about disparities overall. I think you are seeing lower rates of consumption of sugar-sweetened beverages, for example. But understanding whether or not that's actually affected disparities is a little trickier. It's sort of taking the analysis to that next level and really seeing if you've got a bigger gap in some groups, because there's the potential that some of these types of initiatives may actually exacerbate disparities. And so that's a great question. I don't know the answer to it, though.
Thank you for your wonderful talk. I had two questions that I wanted to see from your perspective what you thought. One is the idea of targeted versus not targeted solutions. You showed a lot of data from studies that were targeted solutions, and therefore the initial gap between whites and non-whites seemed to improve significantly, right? The end gap was a lot smaller than the beginning gap. But can you, in general, the belief, at least that I had, was that if you just put a measure across that affects everybody, the gap worsens rather than improve. So targeted versus not targeted solution. And the other one, from a practical perspective, how do you envision in our state or other places in this country with the current social construct that we have, how do you envision having the healthcare system interact, you know, that graph that you showed from Talbot showing 10% is healthcare and 50% is what's happening outside. How do you envision that? What is the practical way to establish that community relationship that would allow to improve health, not just healthcare?
I'll take the second question first, and then I may have to be reminded of the first question. But the second question, you know, how we do this. It's tricky, but I think we've got to really involve a really broad range of stakeholders. What tends to happen is, you know, medicine says we're trying to reduce the rates of this, but there's no recognition that there are programs that are going on that actually may have a profound impact. And that's why that HUD intervention, the moving to opportunity intervention, is so impressive, because it took place as an attempt to improve outcomes, neighborhood outcomes, improve social outcomes and educational outcomes for low-income families. It actually had mixed results on educational and employment opportunities. And those were related to how old the kids were when they made the move in some cases. But I think it shows us that there are these profound impacts that we can at least measure, that happen as a result of these types of interventions outside of healthcare. Now, what that means, it doesn't mean that we as a healthcare system have to take that on. What it does mean is that we have to be open to examining the health impact of a lot of these types of efforts, and then leveraging those efforts, really thinking about strategic ways that we can work with housing, we can work with transportation. You know, they're actually now within, I think, in a lot of places, but definitely in Department of Health Services, you used to have a doctor sign off if you needed transportation to the clinic. And now they can get Uber or Lyft or, you know, some taxi service just by putting in a form. The patient says, I need this in order to make my appointments. And now there's this partnership that's happening where the MAs are the medical assistants are facilitating that interaction. It does take some more time. You've got to make sure then you have enough MAs to do that work. But I think we also recognize that it means more people are coming to their appointments and they're coming on time. So it's really thinking about that cost-benefit equation as well, because too often we focus on, well, this is outside of our realm and it's a cost that we're sinking money, dollars, and time into. But if on the backside you end up with true benefit, in terms of patient outcomes, true benefit in terms of costs, lower costs because patients are actually coming to the appointments and providers aren't sitting there waiting, then you actually may, I think recognizing that those return on investments may be quite high is really important. But really thinking about that social ROI is something that we haven't done enough of. Going back to your question about targeted versus general interventions, I really think you have to have both. And I think what the colorectal cancer screening intervention really did both. The idea was it applied to everyone across the board. But then what they added to it was they identified ways to make sure that African Americans in the community, that the providers who served African Americans were part of the process and part of the discussion. And they could say, hey, you need to tailor this component to make sure that people get the message and that they understand what we're trying to do here. So I think, the interesting thing about that example is CRC screening rates went up for everybody. And there are the temporal trends were in that direction. But I think we saw that this improved outcomes for everyone in the state, but you had this differential improvement for African Americans there. So I think you need to, having both in place is the optimal approach. It's rare that one across the board intervention is going to improve outcomes differentially, though it can happen. But as you said, the more likely effect is that, or at least in some cases, is that you actually see an increase in the gap. With improvement, some people benefit. Those who are already advantaged may benefit disproportionately. Mm-hmm.
We're actually out of time, so if people have further questions, please come down to the front. But let's give Dr. Brown another round of applause.
Thank you.